are already causing health problems, including increased heart-related illnesses, waterborne infections, and mental health problems due to displacement and trauma. Examples of a successful mitigation transformation with health benefits will be presented, including an example of a mitigation project called Cross-Border Excess Stock Transfer, also known as CBEST, which is a circular economy initiative for greening health supply chains in sub-Saharan Africa through a government-to-government dialogue, engagement, communication, and partnership. As a major global contributor to climate change, health professionals have a key role to play in driving change and reducing the high environmental and emissions impacts of the health sector. I'm pleased today to welcome you all to our webinar. I will be chairing this webinar, and I'm Celeste Madondo from WITS RHI. But today we will also hear from esteemed speakers, and I would like to introduce our first speaker, Prof. Eda Weiman, who is an international leader in net zero and sustainable healthcare. She has more than 20 years experience in executive management of academic hospitals, including Germany, Switzerland, Rwanda, and South Africa. As CEO of the My Heart and Research Center, she is leading the development of a center in Kigali, Rwanda, to provide free state-of-the-art cardiac care to patients in need, while minimizing the environmental and climate impact of healthcare. Eda is also a professor at the Technical University of Munich and the University of Cape Town, where she teaches and conducts research on planetary health, climate change and health, and e-health. She holds a Master's of Public Health in International Health Systems from the University of Cape Town and a postdoctoral qualification, and is a specialist in pediatrics. Prof. Eda has received several international awards and fellowships for her work. She is the author of books, book chapters, and articles on sustainable healthcare, as well as climate change and health. Prof. Eda is a member of several international sustainability networks, think tanks, and steering groups, and advises international organizations on sustainability and climate change and health. Please help me in welcoming Prof. Eda, and thank you so much for availing yourself for our session today. Prof. Eda, I know you tried to share your screen. Do you want to try one more time, or do you need assistance?
We try one more time. Can you just do it?
Okay.
Continue. So. Do you see anything or?
Yes, we can see. If you can please put it in slideshow. Yes, it's coming. Yes. So yeah. Yes.
Thank you so much.
I think your settings, because we can see as long as everyone is happy with it, but it's small, and we can see your next slide. So I can see you connected to two computers. Yes.
Yeah. Stop sharing. Perhaps you should do it. I think that's easier. Probably, I don't know how to solve this one. No, you can't. I can't do this because that's too small. You wouldn't see anything.
Should I? Okay, I try.
Okay. It's always overcoming obstacles. So it's the motto of the day. Sorry about that. So then I have to probably close this one as well.
Can you see my screen, Prof. Eda?
No. Uh-uh.
No?
No.
Hmm.
Hmm.
Strange. Let me try again.
No. Here we are.
Okay.
Okay, perfect. Thank you so much.
Please go ahead, Professor Eda.
Okay, so thanks very much for the introduction. I'm very happy to be here with you today and to talk about climate mitigation and a call for social ecological transformation. So we are going to have a deep dive into net zero healthcare and also highlight why is it important to change our narrative that we do have to transform and to engage staff and people. So the content for this morning, for the next 30 minutes, is just to have an example of climate leaders in Africa. I really would like to concentrate on the African continent. Then really briefly introduce planetary health to you, then dive a bit into net zero healthcare and give you some examples of low-hanging fruits and what's doable. Yeah, and then also coming to the question what to do when we are leaving this webinar, what are we going to do at home and as our homework for the next years. May I have the next slide? Yeah, as it has been introduced, I'm currently in Kigali, and we are building a heart care center there, free of charge, and also would like to reduce our emissions so that it is a sustainable health center. But what really attracted me to take the offer and come to Kigali and Rwanda, that Rwanda is known for its climate and ecological leadership. And this, just to give you some examples, it's really driven from the government and especially from the president. So it's a very top-up approach and bottom-down, but people love it, especially the car-free Sundays that happening every twice or once a month. And it's done by the Ministry of Sports, interestingly, and really engages people. For example, you see the Grand Boulevards there, where people walk and take the opportunity to go there, walk there with their kids or a cycle, so they enjoy it very much. Then there are also classes. For example, they play basketball and volleyball or dance classes. You can also, on the bottom picture, you see me there dancing in the back. So it's really for everybody to participate, and people love it. They really love it and like it and participate well. And it's a very nice vibe when you go there, and especially when the traffic starts after the car-free morning, you see what we are missing when we are just going forward as we currently do, and think that that's the optimal thing we can live. But there are definitely ways to live a better life and have a better lifestyle than we currently do have. Next slide, please. So there are several other examples in Rwanda. Rwanda is called the Switzerland of Africa. It's super clean. I've really never, even in Europe, it's difficult to find such a clean place as Rwanda. So they have banned plastic bags already in 2008. So if you even travel to Rwanda, your baggage is even searched for plastic bags. And you don't see the normal pollution that you see on the landscape normally in Africa, very much polluted by plastic. And it really has a tremendous positive effect. Then they have a community day once a month. It's for 3 hours every last Saturday of the month. One of the last community days was tree planting. So everybody was engaging to plant a tree. Trees were provided and also giving shade. And it gives a really nice community feeling that just under the idea that you give 3 hours of your monthly budget to the community as a give back initiative. Yeah, and then there are also e-bikes in Rwanda already. And they all new bikes from next month onwards, January 2025, will only be allowed that it will be an e-bike. So all other exhaust fumes, diesel and petrol bikes are now abandoned, and only e-bikes are allowed also to have a positive impact on air quality. Next slide, please. So that's in a way not a new concept. You can also look it up in the Lancet Countdown. There are several publications how it can be done to create green cities, better lifestyle, better quality of health, and less impact for our health in cities. And there are also outlines how it can be generated and be implemented. Next slide, please. So what's also important, just and for example, the UN Youth Office is looking after that, and there are many other initiatives that we have: a social, racial, and environmental justice in the transformation process. Next. So in summary, we are currently facing a triple crisis. We are facing the climate crisis, as we all know too well. Then there's this unprecedented biodiversity loss, very severe, and never happened before, not especially in this short time frame. Just the great acceleration of depletion just started in around 1940, 1950s. And over the past 8 years, we are accelerating biodiversity loss. And then we are facing also triple environmental crisis, plastic pollution, as outlined before. There's also currently a plastic treaty happening to reduce our plastic pollution. There's huge waste pollution, also waste pollution of our oceans, and also water pollution with chemicals and other detrimental pollutants. Next, please. So briefly to introduce also the planetary system to you. So the Potsdam Institute for Climate Impact Research, close to Berlin, has also introduced planetary boundaries a couple of years ago. And that's one of the recent reports they have published. So we have really breached 7 of 9 planetary boundaries. You can see it on the left-hand side. So we are definitely moving to the red and very red zone. And it also shows that all our ecosystems are really interconnected. So, for example, when we are just putting a lot of CO2 into the air, it's been taken up as a carbon sink by the oceans, and then oceans, for example, get more acidic, and there are also lots of other changes happening as coral bleaching, as we all know. So we are living in an interconnected system, and have to take note of that, whatever we are doing. Next one. So these planetary boundaries were also taken up by a new economic model, by the donut model that was introduced by Kate Raworth in Oxford at the University of Oxford. And this new economic model really takes into account that we have to live within our planetary boundaries. And unfortunately, what we are currently doing also at universities, we are not teaching new models. So we are trying to solve our current problems with old models. And these models were developed in the 1920s, 30s, 40s, 50s. So that's definitely not applicable any longer. And we need new models, but we also need to teach and prepare our current students for new models, such as planetary boundaries, but also as to the donut model. And the donut model, for example, is also applied in Rwanda quite well. And the Rwandan economy tries to stay, and society tries to stay within these planetary boundaries within the donut model. Next, please. So then, well, the other question that always comes up, why is it so difficult? We know change is difficult. It's always difficult to engage people, but that's really tough, yeah, what we are doing. And the first publication happened in 1896 already, and depicting quite well what's happening now with the climate crisis, and was a first publication on the climate change, climate crisis, CO2 emissions. And they foresaw quite well and described for quite well what's currently happening. And the question is, why is it so much more difficult than all other changes we have done? Next. Well, the answer, unfortunately, is we are just fighting really against a huge, very influential lobby of fossil fuels companies, and they just put a lot of money, billions of dollars, into governments, into policymakers, into political leaders, into the press, into social media, to prevent change. And that's also, well, we saw it at all the various COP meetings, and also currently at the plastic treaty that's happening, that they really try to avoid that change and switching to a cleaner and healthier economy. Next. So that was also taken up by the Lancet report. So the latest Lancet report was published in end of October. Perhaps you have also participated and attended it. And it was also taken up by the Lancet that health is at the mercy of fossil fuels. So our health are really completely now dependent what the fossil fuel industry currently is doing with us. And that's a very bleak outlook. And that was even emphasized again in the latest report. Next. So what's up to us? What do we have to do as we all work in healthcare in different positions? But healthcare is also a central part, and also a central part for change. Next. So we are also one of the culprits. It's not that we are not also contributing in healthcare to CO2 emissions and to plastic waste and water pollution as well. So we are also one of the big emitters. So the paradigm is first do no harm. Currently we do harm, and that's the reason why it also needs to change. So the top 10 emitters of global healthcare, of the global healthcare footprint by Healthcare Without Harm, published, is definitely also United States, China, European Union contributing quite a lot, and within the EU it's Germany and Switzerland, the two healthcare systems that emit the most. Next. So when we look at CO2 emissions or general emissions, probably have heard about it. It's divided into scope 1, 2, and 3 emissions. And for example, on the left-hand side, that's the normal emission regarding our industry. And if you translate it to healthcare, scope 1, for example, are direct emission coming from the facility, from the healthcare facility, for example, from generators that also produce quite a lot of CO2, and other pollutants. Then the indirect emissions when we purchase, for example, electricity, gas, fossil fuels for our energy supply. And scope 3 emissions are all other emissions. For example, if patients need to go to facilities, that's one of the scope 3 emissions, but also all that comes from the supply chain. For example, when we purchase medication, for operation, everything what we purchase in the supply chain belongs to scope 3 emissions. And unfortunately, Scope 3 emissions are difficult to tackle. It's not impossible, but they are difficult because as we are in a global economy, I think a computer travels 300 times around the Earth before it lands on our desk. So it's a lot of emissions that are being produced there, and healthcare, depending on the country, and the different data also available from Healthcare Without Harm, depending on the country, Scope 3 emission makes up between 60 and 75% of emissions. So it's a huge chunk of emission that we need to tackle and have to reduce. Next. So the paradigm, as you know, it's the bigger the better. It's still, we are all still talking about growth, the growth of our economy, of our health system, whatever, the growth of our houses, of our wealth. But growth within a finite planet is quite contradictory. As you know, we are currently using 3.5. Earth is just to maintain our current standard of living. And that's not possible if we want to or have to live within the planetary boundaries. And the other paradigm is also that we have the notion that more CO2 is always means always better health care. There are multiple examples that this is not true. One of the examples are, for example, the US healthcare systems that produce a lot of CO2 with partly very little and very unfortunate outcome. For example, if you look at the US infant mortality rate, that's far higher than most of mortality rates in Latin America and in other countries. So it's not a good, it's quite a good example also to show that the more CO2 doesn't mean better health care. So we need to move from resource intense, that means CO2 intense healthcare, to quality healthcare that also means an integrated, smart, and lean healthcare approach that we have to use in the future. The aim is really to improve our healthcare and our healthcare outcomes within our planetary boundaries. And we have already overstepped planetary boundaries and healthcare. For example, as in many countries, for example, life expectancy also in high-income countries is already decreasing. Next. So the aim is to introduce and transform to a net zero healthcare system. Next. And I would like to show you with some examples how this can be done. And this is also from own experience, also international experiences. So what you, for example, could do, this is when you look at the figure on the left-hand side, engage, for example, in green procurement, reducing the CO2 emission of the supply chain, really looking for more local solutions, have green buildings, green operations, then also engage quite a lot in awareness and education. So people won't listen and follow you if you do not really put a lot of time and effort into education and awareness. Sustainable medication, circular economy, plant-based food, also an initiative, sustainable waste management, e-consultation, and for example, electronic fleet, solar panels, and becoming more autonomous in energy supply. And also, for example, have a biodiverse garden and greenery. It's good for the mental health, but also engaging patients, staff, and even the communities. So then also it's nice to have new models. One of the new models is, for example, the DAO model that really puts sustainability in the center of all operation, and that needs to be, and then arrange around leaderness, patient-centeredness, improve team skills, and apply, for example, the balanced scorecard. What's also a great tool to do, also developing a dashboard and really showcasing what you are doing, what has been achieved on a monthly, yearly basis, and highlight, for example, also measuring and highlighting also the reductions on the bottom part, then also engage in an interdisciplinary zero emission team. And that's also nice if they come from different, if they have different backgrounds, different disciplines, also to feed in and enhance the discussion and how to move forward. And also information and education of staff and patients is very important. Next. So what we did some time ago, for example, at Großes Cure Hospital, not at the beginning of our initiatives in green health care, but just on the way to do an environmental fair, a green fair, and there was just different parts. So showcasing, for example, by the staff what they are doing, but also by retailers, what's on the market, what's available regarding sustainable healthcare. But we also did, for example, a conference, how we can engage and implement in net zero healthcare in our healthcare facilities, but also locally and nationwide. And that was very much appreciated by the staff and by patients, and it's still happening, and was really, people had really taken it on even after I left. And it's really encouraging also to see how staff is engaging in these events. Next. Yeah, there are so many ways we can engage. So these are definitely also low-hanging fruits. So for example, if you do a plastic survey and really just look, or plastic audit in your hospital, and for example, you take the time just to look at the ward, what plastic is being produced there, and there's so unnecessary plastic, for example, from this butter packaging that's not necessary. You can also find other solutions. Or for example, if patients get their medications or even not get their medications, or you prescribe medications, really look up what's still available, that you ask the patients to bring in their medication, not to prescribe unnecessary medication and medicines that are still available at home. It's quite costly. It's very expensive also for the healthcare system, for the hospital, and it also produces a lot of waste that normally goes into the wastewater or the water in our rivers, into our oceans, and has then other effects on us. So that's a very easy way to monitor it and reduce. Next. So what we also do, that should be a very easy way to do, but in fact, it's not really. So you also need some introduction and some learning about it, how to separate in paper, plastic, and metal, for example, and general waste, and also some education of staff, but also patients is needed, because most of them are not really used to it. Next. And as you probably know, we also had not only energy crisis, but also water crisis in Cape Town. So we were also running out of water because of a severe drought. So we also had to recycle our water. What we did currently, they are facing a water crisis in Johannesburg, because they also do not have enough rainfall there. So it's coming up with climate change, and we need to get prepared and to save our resources such as water. Next. That's also a very good way. What we did, for example, in waiting areas, just to put a board up and introduce the subject, what we are doing, why we are doing it. Next one, and what you could also do, and what's next slide. I did together with the School of Film and Theater at the University of Cape Town. Some students made a video cure goes going green. So you can also have a display in the waiting areas and show to your patients, but also to your staff what you're doing. And it's a good way to introduce the concept and to raise awareness. Next. So just a brief outline what we're currently doing in Rwanda. So we are building a hospital, a cardiac care hospital, heart care hospital there in the healthcare, new healthcare center, Masaka Healthcare City. So we currently engaging to get funds, green funds also from the German government to implement solar on the roofs and on the parking. And we also have implemented quite a lot of other sustainability standards. For example, we definitely want using the local supply chain to reduce carbon emission and transport emission. We are implemented natural ventilation to reduce air conditioning. Then also engaging in and planting a biodiversity garden. We have put stormwater drainages in place because rainfalls are getting heavier and heavier due to climate change. We try to be energy efficient and also engage in electronic records and IT network to reduce the amount of paper and to become a paper-free hospital. Next. And this is also written up in a sustainability report, and that I could, for example, also recommend to everybody just to do a sustainability report, just to see the gaps, what you want to do in the future, and also think about it strategically, what can be done and how it can be achieved. Next. So that's in summary possible clinical intervention. So plant-based diet, we introduce, for example, a meat-free day per week. That's even ridiculous, although very difficult to achieve, but still ridiculous because all the dietary requirements say that you only should eat a maximum of 2 meals, meat meals per week. And we do it far beyond this, and also introducing a lot of diseases such as heart diseases, arteriosclerosis, and many other diseases. Engage in low emission inhalers. Some countries have already switched that to inhalers without propellants. Green operation theater, it's a great area to do a lot of work because we produce a lot of waste. We do not segregate well our waste, and we use a lot of single-use items and create a lot of environmental impact. So that's a great area where you can just also have a huge impact. Then switch to low carbon anesthesia, for example, phase out desflurane as done in Scotland, because desflurane stays 15 plus years in the atmosphere and causes a lot of damages, and switch to intravenous anesthesia, what's also possible. And there are also recommendation available from the NHS and societies and available online that you can look up and implement more circular healthcare to get away and drive the single-use plastic use to more circular economy healthcare applications. Next. These are some leadership options for you. So it, in a way, also has to come more from the top, not the very top, but it's definitely a leadership thing. So cycle to work initiatives, free public transport, give free bus tickets, for example, for staff to come to work, community gardens as a reach out, also to engage with communities. Then also apply integrative healthcare together with community to really also engage more in reach out, that not everything is done in parallel. For example, whatever can be done not in a hospital is definitely done in a hospital very comes with lower carbon emissions, so have digital health. But that's also not the solution, because also it uses a lot of energy, so that you have to be careful how to implement, and having green healthcare focusing on more on the well-being and not so much on the just delivering healthcare, but really looking for the well-being of people. Next. So there are some publications we started with, that was before some time ago at COP21, that you can look up what we did in, for example, in Cape Town, and another one. Next. That's a newer one. If you want to look up some ideas, some ways to do it, where you can start. For example, that's also another publication that's available online. Next. So that's also very important. We need to communicate and to transport it. And when you start communicating about climate change and climate crisis, as you know, do not expect too much knowledge. The knowledge about climate change, everybody has probably heard about it, but most people do not really know what it really means. So do not expect too much knowledge, and really make it tangible for your audience. So coming to an end, next one. So what do we do? What do we need to do now when we are just finished and want to implement it in our healthcare facilities? What to do? Next. So we, as mentioned, need to talk about it. We need to talk to our peers. We need to talk to our staff, to our colleagues, and definitely have to talk with our patients about it. And it really has also health effects, as heard in the introduction. Then we also need to be active and elect climate conscious political leaders, then also create awareness. Most importantly, be active, do something about it. I think that's very important, and really connect climate to health. And that's not well established, even in healthcare professionals. When, for example, I mention, or I've been asked giving a talk on climate change and health, I often hear from health professionals and really specialized health professionals, are there any, is there any impact on health by climate change? So that's still not well established. Next. So in conclusion, we need to deliver healthcare within our planetary boundaries. That's quite important. Think about the 3.5 Earth. That's not sustainable. Then the neo-economic models of healthcare based on the more technical, the better vision is not sustainable within our ecosystems, health systems, and within our societies. And net zero with continuous decarbonization of our healthcare system is definitely a priority, but also the establishment of lean, low-tech, and integrated healthcare models. So we have to think about what's really the best for our patients, and how can we deliver healthcare with a low CO2 footprint. Then planetary health definitely has a part to play and needs to be an integral part of our medical education. And last but not least, it's important that we are definitely driving the change. We are the change agents. And if you look at it, there's really much we can gain. There's much health we can gain. There's much well-being we can gain. But there's also a lot that we can lose if we do not act. And the last slide, please. So in a way, everything starts with an idea. We are trying to create ideas. So also ending with saying tomorrow is today, and begins first as an idea in each and everyone's mind and soul. And I think that's the reason why we're doing this webinars, just to create ideas and ways and imaginations how we can move forward. Yeah, and last slide, please. Thanks very much for inviting me. Sorry about the technical issues. I hope that you can get something out of it, that you can move forward in your own facilities, in your own healthcare facilities. And thank you for listening and your engagement.
Thank you. Thank you very, very much, Prof. Ida. You highlighted, you showed us that, yes, it may be complex at the beginning, especially when we look in the context of healthcare, but it is possible. And so we are going to open for some questions from the colleagues online, and just the fact that you highlighted, the need for education and awareness and continuous active engagement, and find creative ways to communicate the very important topic on climate and health. So I'm going to ask I'm just going to open for a few questions from our colleagues before we introduce our next speaker. So I will, yes, so if you have a question for Prof. Ida at this point, I'll allow you to raise your hand and she can take a few questions. I don't see any questions. Let me just see. You can also have a question in the chat if you have. Let's see. So while people are thinking of any questions that they would like to ask Prof. Ida, what I'll do is I can introduce the next speaker while people are thinking of questions. But if you do have a question that comes to mind, please do share it in the chat, and Prof. Ida can also then respond to those questions in the chat. Our next speaker is Mr. Justice Gandu, who is the founding director of Spectrum Africa Healthcare Initiative. It's a Kenya-based nonprofit. He has 25 years of work experience, of which 15 years he spent in global health and market access for infectious disease as a regional manager for East and Southern Africa at the Clinton Health Access Initiative, and 10 years across diverse private sector industries that include agribusiness, manufacturing, educational consulting, renewable energy, and he's experienced in strategy, operations, project management. Justice holds a BCom degree from the University of Nairobi and a postgrad in operations and supply chain from the University of Liverpool. He is also an avid cyclist, so key to the point, cycle more, as Prof. Ida also mentioned. And this brings out even more his intensity and passion into every area of his life. And so I will allow Justice to please, do you want me to share your slides, or will you share it on your side, Justice?
I'll share it on my side. Thank you.
Let's go ahead.
Let me know if you can see my screen.
It's still coming. I'll let you know. Yes, I can see your slides. Please put it in presentation mode.
Are we there?
Yes, I can see it. Yes, it's clear. It's perfect.
Thank you.
Please proceed.
Thank you. No, I have 20 minutes, but I'll try and do it in less than 20 minutes. Thanks, Professor Eda. That was a nice sequel to my presentation talking about plastics and circular economy or circular healthcare, because what I'm going to talk to you about is around the same. So this initiative also came to me as an idea, and your last slide was talking about projects coming through as idea. And it came to me as an idea while I was based in Maseru, the Kingdom of Lesotho. That's where I started this exercise. So why the on supply chain in healthcare? It's because it's the biggest emission segment in the value chain in healthcare sector, accounting for 70% of emissions profile within health. And health is the fifth largest emitter. As you've heard from Professor Eda's presentations, around 5% as a global emission from healthcare sector. And the Economic Times report of last year indicated that organizations will definitely help the world to achieve net zero if we focus on fixing the supply chain. So it's all around how the movement of commodities, regardless of the sector, it's all around the movement of commodities from extraction, production, transport, utilization, and disposal. And we are in this climate situation or climate crisis because of our pursuit of profit and also our pursuit of convenience. And I think we now need to go back and check our moral values in terms of how we are damaging the world. So we are looking at optimizing regional supply chain procurement and in Africa through three approaches, looking at how to bring country context to limelight and linking those to policy framework, and then resources that can help address those issues, and then preparing the marketplace. Market shaping is one of those things we do towards climate positive growth. The framework for supply chain, and I know Celeste, you're from supply chain background, so this should be music to your ears. The framework for supply chain has three segments: the first mile, second mile, third mile. But I bring in demand planning because our waste problems start from our indiscretion in decisions, especially in health sector. The forecasting and quantification assumptions we make, and our tendency to use multiple procurement mechanisms where we have the mainstream mechanisms and then we have bypass emergency ordering mechanisms. So having been in the health sector for 15 years, one of the things I noticed, assumptions used to quantify and forecast for medicines sometimes is not driven by epidemiology alone. It's driven by the extenuating factors around when will government release the funds. Let us buffer our stocks by 2 years. When will Global Fund come through for us? If it's going to take long, let us buffer our stock by another 1 year. So there's this entropic accumulation of products, and that has normalized the health sector into more of an overstocking entity or an overstocking sector. So what we see also is there's a challenge with the disconnect in the chain where high-income countries have good intentions for low-income countries, but sometimes the intentions are not well informed. So you find ultrasound equipment is donated, softwares are not being upgraded, and it cannot work in our context. Or radiology equipment has been brought, but there's no skilled person to run it in the location where it was donated. And so these things add up to the medical waste. So we are in this boat where the LMICs are suffering from being a net medical waste importer, short expiries. We've seen the same case with COVID vaccines, where when they were needed, there was immigration control, but now that they're not needed, they are becoming more common in our region. So we have to deal with disposing them and managing that waste. So our decision is the biggest problem in generation of waste. This exercise I'm going to talk to you about is focused on the middle part, which is just touching on, my slides are not moving. Yeah. Okay, it's moving now. So it's touching on central level where wastage, and this is all around the central or national medical stores. This is the center of the work I've been doing in this space, because on one hand, the health advocates are raising clarion calls on patients in low-income countries are not having access to medicines, but the same medicines are expiring at central medical stores. So I didn't understand that script, and I got involved, and I found that there's a normalized wastage of medicines at central stores even before they are outbound to facilities. And that is what now I sought to address in this exercise. So driving mitigation exercise in healthcare requires you to have data. And so I just did a quick run on data on pediatric ARVs, looking at the world's procurement mechanism. And this is data I picked from the AIDS Procurement Working Group, which sits in Geneva, chaired by Global Fund, and has multiple players, including KEMSA of Kenya, South Africa, NDOH. There's EPSA Ethiopia, and a number of countries, and PEPFAR as well participates in the group. So looking at the pediatric procurement in 2022 alone, countries that submitted their orders, forecasted orders to the port.org over-procured what they forecasted for by more than 25%. And in some cases, like Abacavia, 160 pack, they were buying more than 10 times what they had forecasted. And this is just the APWG data, does not include USAID PEFA data, because USAID is also another big buyer of ARVs. And I don't want to show you the adult numbers, adult statistics, but this is just pediatric, because we know we have not achieved treatment parity between adult care and pediatric care. Adult care is above 95%, pediatric is still oscillating around 70 to 78%. So even for pediatric program, we are over procuring. And so there are those medicines, ARVs, that WHO has indicated as a limited use, they are also still being over procured. So most countries are going beyond their forecasts to over procure. And this is what is leading to waste. And when you run this triangulation further on terms of the numbers being reported for children 0 to 14 years, that children and adolescents 0 to 14 years with HIV AIDS, 90 countries reported, 90 LMICs reported 880,000 children on treatment. Remove the population of children in high-income countries, you are left with 846,000 children in generic accessing low-income countries. Then further remove the population of children in countries like India that are not represented in this procurement because they have manufacturing next to them. Manufacturers deliver to their facilities. Then you are dropping down to 602,000 children. And then remove those countries that have preferences like Uganda or Botswana, they have preferences for local sourcing, local suppliers. So they don't report on this portal. And so it drops down to 542. And then you have specific situations where formulations, children have added weight because pediatric ART dosing is sensitive to weight and age. So there are those children who have gained weight and they are now on adult formulation. And that drops your number down to 485. And eventually, you look at the formulations not represented within this cascade because some of them are being phased out and the likes. And the population you're left with is 325,000 children in LMICs reporting on this portal. So the numbers we are procuring is over and above even the target of patients we are trying to provide these medicines to. Then layer on top of it perfect mechanism and other pipelines of procurement. So this is how waste keeps in the system. And so I did an analysis across 20 countries just to understand what drives the control tower challenges for procurement and supply chain management. And it's all zeroed around 4 buckets. One is there is a synchronized timeline between governments and key funders like Global Fund, PEFA, and other mechanisms that are there. 2, there is legal bottlenecks where countries have preference for local suppliers who have no capacity. They do not even have the stocks. And sometimes they have to go buy from private sector expensive margins, profit margins. And that then makes them fragment the deliveries. So you can't, if you put a tender for 300,000, you can't get a full shipper. You'll get it delivered in 400 packs, 50 packs, 20 packs, and the likes. And that creates a stock out. Then you have a challenge around optimizing guidelines in each country in line with WHO normative guideline changes. The process of new guideline revision requires civil society participation, faith-based community, and it's a long iteration that sometimes delays the process of adoption of new guidelines. And so the procurement agents like central medical stores end up continuing to buy more of the legacy stocks that the new guideline is phasing out. And then the product transition challenges where you bring a new novel product, but market complexity means there's probably the supply is lacking active pharmaceutical ingredients, enough quantities to be able to meet the demand, or probably projection. The health economists did not do proper projection of the APIs needed to deliver the new product in the market. So this is just it's like a Russian roulette. This is just what brings all this complexity around overstocking, understocking, treatment disruption and expiries. And so we embarked on a process which we call cross-border excess stocks transfer. One of the things that I noticed is that not all countries, when WHO changes guidelines, not all countries adopt changes in tandem. There are early adopters like Kenya, South Africa, Nigeria, then the mid-tier, and then the late adopters who are waiting on others before they can change their guidelines and take on the new formulations. So we the mechanism that came up was a voluntary social license between central medical stores and ministries of health to just exchange excess stocks. You have excess stocks you're facing out as legacy, but another country has not adopted changes in their guidelines. Give it to them instead of banning it in your country. Because that one bottle, most ARVs are packaged in the high density polyethylene, and we have different polymers in the market. There's a polypropylene, which is mostly used for textile, fashion industry, and then there's also polystyrene, which is mostly on the foam, solid foam. I think they use it with a bubble wrap for packaging items. So this particular sector is identified with the high density polyethylene, which is regulatory approved by stringent regulation authorities. And 1 kilo of that plastic HDPE releases 3.11 kilos of CO2 when burnt in suboptimal conditions. And so that is why we embarked on this exercise. There is no need of banning medicines in one country when the next country is talking out of the same medicine. And then you are still emitting CO2 into the environment. Because with medicines and pharmaceutical sector, it's only one-way ticket to incineration. If it is expired or it's not usable, it has quality compromises. And so Spectrum, through the Climate Health Impact Lab, innovated the circular economy solution, what that we call in CBEST, to be able to bring a social license across countries. And that is how we ended up testing the market. What is the common challenge with Africa? Our borders. And we questioned why, for pandemic and climate effects, Africa has no borders. We are all unified, like we are all suffering together. But when it comes to immigration, trade policy, and labor, apparently there are borders. You start seeing a spectrum. The word spectrum there has no connotation with my company, but you just start seeing a spectrum of borders where you are given rules and all. And the question we postulated here is, if all central medical certified on good warehousing practices, they're handling health product and technologies that are approved by stringent regulatory authorities, they have ISO certification on quality management system, they have certification for some pharmaceutical conformity, pharmaceutical products, which have gone through GMP, they have qualified pharmacists, they have SOPs and compliance certificate, then why can't they exchange these products? And in testing that, we realized circular economy could actually unify countries around one African health sovereignty while achieving climate positive growth. So we are improving access to medicines, and we are also minimizing burning of waste at central medical stores. And so we participated in this exercise. Without a single investment of $1 or a shilling from my pocket, we were able to save $1.5 million worth of products from expiring across East Africa, Southern Africa region, and Western Africa region. Majority ARVs, a few of opportunistic infection drugs, TB drugs, and advanced HIV disease diagnostics. And that translated to close to a 50 metric ton CO2 emission averted. But what we were not able to deal with, because countries were reaching out to me when they were left with 1 week to expiry, or the guidelines have just changed and they don't know what to do with, it was difficult to move those kinds of product offers. And that amounted to $17.2 million worth of waste, which equated to 386 metric tons of CO2 we could not avert. 53% of that came from one country, and 65 tons of that came from the private sector. So it's a holistic thing that we need to work as multiple stakeholders, transdisciplinary approach to be able to address climate health impacts if we want to achieve sustainability. But from this initiative, without a single investment of $1 or a shilling, we were able to realize healthcare without harm. Because you imagine the total tonnage of plastics we were able to move was 16,000 kilos or 16 tons of this HDPE. And what we were not able to move was 104,500 tons of plastic, which had to be burnt. So we were able to get saved value for money. We were able to avert emission of short-lived pollutants, and we availed 20,000 patient doses in countries that had stock-ups. So at least guaranteeing quality of life adjusted years to patients. And so we looked at the whole process of the circular economy. There are very many ways of defining circular economy, but we condensed it into 11 ways. And we found that our CBEST initiative was able to utilize 3 of those 11 ways of going circular to counter the high-density polyethylene mission at level 1, which is central or national medical stores. And we decided we are going deeper with the innovation in this area, as well as wider with strengthening systems and policy. And we noticed this was addressing 4 of the 17 United Nations SDG, that is good health, responsible consumption and production, climate action, and partnership. This would not have thrived without partnership, reaching out to different partners to listen to us, trying to assuage the revenue authorities in different countries not to tax their products and all those kind of things, because they are donations from government to government. But there are those areas which we realize we need to now backpedal. Like, for instance, how do we infuse design in the manufacturing of these products so that we use monomaterials, biodegradable materials in packaging? So those are things we have packed for. We have deferred for market shaping. So we are now building partnerships, political partnerships, to try and drive this agenda differently. But it's a more long term. For immediate term, we were just focused on innovation and system strengthening. And so, in a nutshell, that's how we were able to achieve a circular economy innovation with CBEST. And for our next steps, these are the countries in green that have participated in this initiative. Most of this, I did them while I was stationed in my house in Nairobi. And it was easy to coordinate with the different permanent secretaries or principal secretaries of the Ministry of Health across these countries. I've never met any one of them, but our emails have been flying around. They have been giving approval, and things are moving across different countries. The yellow countries, or is it cream? Those are countries that expressed interest, but because of technical challenges in their processes, they did not move the needle in terms of participating in this exercise, but we still have them under radar. So we want to build this as a blockchain solution, as Africa's first virtual health stock exchange, to address the challenge of national level stock out, so that we can, national levels expiries, so that we can have a mechanism where medicines can go to the facility, to the last mile, and even up to the last meter, so that patients get access, and we are protecting the environment from this waste, burning of waste. So we are in the middle phase. We've proven the concept. We are now in the middle phase of doing the partnership fundraising to build the platform so that we can socialize it with the likes of Africa CDC to take it up, because for us, our agenda is to build, operate, and transfer to people who have the political muscle to drive it. So we are hoping we can transfer to Africa CDC to be able to manage this e-commerce. It's a business-to-business e-marketplace for engaging and socializing central medical stores and ministries of health to be able to collaborate on early warning for stock management, early warning for procurement. Do I have to put an emergency order to India when I'm in Kenya and I know Rwanda has the stock, or I know Tanzania has excess? As we speak, one country reached out to me with 105,000 pieces of copper IUD for SRH. This is the first time I'm getting an offer from Sexual Reproductive Health Program. So imagine somebody invested in mining copper, probably used child labor, processed that copper, sold it. It was used to produce the copper IUD. Now it has been procured, it's excess, it has to be destroyed. The circular economy has to work in a way that it makes business sense. That's why we are in it. And so going forward, what are the lessons we've learned through this process? Well, first of all is 200 nations have been meeting for the last 2 years trying to define the plastic treaty, and it's not going anywhere. While they are delaying and the oceans are getting destroyed and our waterways are getting damaged, why can't we leverage circularity as one of the pathways out of the deadlock so that we can address the triple planetary crisis that Professor Eda was talking about? And we can actually achieve this by looking at the design of our packaging, looking at whether we can have alternative mechanisms, thinking about monomaterials that can work, or if biodegradable options are already getting in, how can we scale those and work with regulatory authorities for their expansion so that we can be compliant with nature? And this is where we are saying health sector and oil and gas are still stuck in the linear economy, which is very expensive, wasteful, and loses value creation because it's single use. You have no other pathway with a linear economy. So we need to move healthcare sector and oil and gas sector into circular economy. Recycling economy is there. While it is good, it cannot achieve as much as we would have expected for a resilient world. Because with recycling, yes, the world is, at this point, fashion industry is only 3% circular. And then we're also finding the world is recycling less than 9% of the waste that is generated. Few industries that are doing recycling are like the electronics. We are now able to see refurbished computers, refurbished mobile phones, and the likes. How do we get healthcare into the recycling and beyond the recycling into circular economy? Knowing that the 11% of all the oil manufactured by the world goes into plastic industry manufacture. And pharmaceutical packaging is one of the absorbers of that segment. So we need to reorganize the world order through circular economy. We look at our moral values in terms of how there's need for a behavior science approach here, because we are acquiring, even when we know we don't need it. So how can we temper our wants versus needs and find a way in which we can work within planetary limitations that Professor Eda was talking about? Then the other lesson we need to address is psychological blindness in our collective action. So this one, I picked it last year when Kenya hosted the first ever Africa Climate Summit. One global PSM, procurement supply chain partner, was celebrating on the Zero Emissions Day how they have quantified a 21% reduction in CO2 through volume aggregation by bundling and shipping 83.8 million bottles of ARVs to 34 countries in Africa. And so technically, they averted 1953 metric tons of CO2. However, that same week, one country was destroying $12.5 million worth of expired drugs and medical equipment in the national medical stores. And this sea-based initiative has been unable to move $17.2 million of ARVs that would have amounted to 435 metric tons of CO2 averted. So looking at these numbers, you start asking yourself, is it better to ship this kind of volumes for African countries when we cannot absorb it? And why is Africa then cleaning up for the rest of the world in terms of being a net medical waste importer? Can't we sanitize versus want so that at least we know we are receiving what we actually want and we can consume? And I know we have to prepare for emergencies and all, but we have to work within certain bounds in this process. Another example I want to share with you is on introducing climate smart drugs for low carbon sustainable systems. So the world is now celebrating how we can decarbonize existing drug regime without increasing production costs. And in HIV prevention, some key populations are being targeted with cabotegravir via long-acting injectable and also lenacapavir via long-acting injectable as alternative to the oral ARV that is taken by populations at high risk of HIV infections like commercial sex workers and men who have sex with men. And when you think about it, when you bring an injectable in place of an oral, at the country level, you're going to need syringes. These are single use and they're petroleum-based. So then we need waste bins and all those kind of things to manage this waste. So we are having a more layer of headache in waste management because of introducing a new technology. While the cabotegravir via long-acting and lenacapavir via long-acting are very good and effective, and they're able to reduce the production cost in India and other places by 21%. We need to quantify the waste that will be generated by using the syringes in these countries of ours as we introduce this new kit. So there's that psychological blindness that we need to address as we take a holistic approach into managing climate and health issues. And the third lesson is, and Professor Eda also mentioned leadership. The third lesson is what kind of governance is needed in an interconnected, complex system. Let us shift the narrative. Let us not just be keen on reporting, but also realize we need to be doing this practice even at our own individual level. You saw Rwanda, they're taking walks, cycling, and doing those kind of things. So we need to inculcate this in our own lifestyle. Let us know that sustainability reporting and disclosure are tools that matter, but they are a mirror, not the mission. The mission is for you to practice everything you say you must do. The strategies you're formulating as organizations or institutions must be health-centric and nature-positive. The decisions we make around procurement must be health-centric and nature-positive. Actions we take must also follow the same algorithm so that we can have a meaningful change if we really want to reduce our footprint and emission. But we also need to determine the trade-offs through a purposeful, sustainable framework. We need to determine the trade-off in an interconnected system. Are we supposed to pursue climate change? Are we supposed to pursue health equity or inequity, or social equity or inequity, or economic growth for our businesses, or environmental justice? Or should we take all of them holistically So that needs thinking and needs cross-sector coordination and also needs transdisciplinary approach, including behavior science in it. And I'm an ardent fan of behavior science in driving climate change. And so in a nutshell, if we want to catalyze transdisciplinary climate action across multiple sectors, let us consider innovation in circular economy. Spectrum has already set up the Climate Health Impact Lab, which we are calling CHILL, to be able to churn out innovations, which we are calling ICE, to be able to address the global warming. I'm leaving you with pictures of some of the patterns of medicines that were able to move across countries. This was 300,000 packs of dolutegravir that was going to be burnt in one country when the neighboring country had a severe stockout, and the civil society had taken the MOH and sent the government to court for denying them access to medicine. And we came through for them, saving close to $900,000 worth of stocks from being burnt. Thank you so much, guys. And back to you, Celeste.
Thank you so much for that insightful presentation and just showing us what innovations and what is possible. But I know there's also the delicate balance when we look, especially when you look at supply chain, the delicate balance in terms of, yes, rational medicine use, forecasting, but most importantly, when we look at universal health coverage, just the access, ensuring, looking at it equity and making sure that people actually have access to medicine. And I have a lot of questions or just comments on that point, but I will allow just for a few questions. I know we have like 1 minute or 2 minutes left, and so I'll just see if there are any questions from colleagues online. To either Prof. Eda. I see Prof. Eda's hand is up. Please go ahead, Prof. Eda.
Yeah, if you allow me, thanks very much for the great presentation. Really enjoyed it. Look, we lived in a circular economy 100 years ago. Yeah, so it's not a new concept, but it's also driven very much, as you also pointed out, by the driving forces behind it, all the fossil fuels and what other companies. I just want to give you one example we did in Cape Town and also in my hospital. And I think that also should be highlighted. It's also about saving money and making our healthcare system more resilient. And we know that we need more money for climate change related diseases. And you can save enormous amount of money if you, for example, purchase in a different way. And we did that also in a hospital, and our, for example, cost for medication dropped 2/3. So we saved really a lot of money. And if you want to just get a buy-in from hospital managers and management, and especially from economists, I think it's always good to point that out, that how you do decisions, what you decide you need, if that's really relevant for the health and well-being of a patient, what really need to be purchased, that's critical, but that's also a lot of change and mindset change needs to happen. But at least I think that should be pointed out, that you can save enormous amounts of money if you do that.
Thanks. Justice, do you want to react to that comment while I see if there's other hands?
It's self-explanatory. Let me give the others a chance to ask questions, but thank you, Professor Eda, for that.
Are there any other questions from colleagues? I think that's an old hand, Prof. Eda. Okay, I see Jean. Please go ahead, Jean.
Hi, and thanks to both speakers for really interesting presentations. A question that I had is, in terms of getting buy-in from stakeholders to implement these changes, we often find in our projects that working at the sort of facility level, there can be a lot of buy-in, but trying to translate that enthusiasm higher up the chain at maybe a provincial level or higher up becomes more challenging. Are there any suggestions or tips for maintaining enthusiasm as you try to scale projects up higher up the food chain from either speaker?
So, Justice or Prof. Eda, yes?
I'll go after Professor. Is there any tips there?
Do you want to go ahead or?
Okay.
You can start.
Yeah.
Okay, thank you. So what I can say is one of the things that has really helped me is to take a very simplistic approach to matters in health, in interconnected complex system. I think sometimes we, like climate, I've noticed it feels so alien and abstract because people cannot relate with some of these issues. And I think I came from a consulting background. I was with Deloitte. And one of the things I learned in strategic selling excellence is to be able to speak to someone in their language. So it touch their pain points. So I went to the central medical stores and I talked to the director general and I asked him, what is your biggest problem? And he told me that expenses, running the operation is the biggest problem in terms of cost containment. And I switched that gear. Let's not look at cost containment. Let us look at the value chain problems that are leading you to cost issues. And I found that there were leasing warehouses to store expired medicines that they were going to ban. And I brought him a different angle. Why should you lease warehouses to store medicines that you're going to ban when we can donate the medicine? And that's when we saw the picture. And that has never worked in Africa. We are not a manufacturing company. So then give me the medicines. I try to transfer them. And I transfer the medicines through this process. And that woke him up when he realized I don't need to continue leasing warehouses to keep medicines that I will ban when I need new procurement to come in. So go to somebody with their pain point, speak to them at their issue. And I believe even in cancer management, one of the things I picked from a patient is sometimes all they need is hope. Before you bring the algorithm of treatment, sometimes they just need to be reassured that they have life. They are not on a countdown. So it requires, I don't know which school teaches us this, but it requires that kind of approach. Talk to somebody along their pain point and walk that journey with them and show them an alternative way, and they will wake up and they will be your ambassadors. Because now the central medical stores directors were able to now bring it to the PS level and to the ministers level. So I didn't need to do anything. I've never met any of these ministers, from the former Comrade Chimetsa of Zimbabwe to Diana Twine in Uganda to Mentene in Lesotho to yes, in Kenya. I've never met them in person, but people were speaking of this initiative on my behalf because we address their pain point. Thank you.
Thanks, Justice. Prof. Eda, do you want to just reflect as well? And then I'll ask Jaimini to ask a question, followed by Elodie.
Yeah, well, I just would like to elaborate that I think talking to people really facilitates a lot, as Justice has also mentioned, and just talking to them and addressing the issue. And what also helps, what I found, normally there is a policy around sustainability policy somewhere in the pipeline or in the government, and it's always good to have something in writing or a directive and show them a directive. So in a way, persuading them and showing them you're just following the directive if you just change your day-to-day practice. And that's also quite helpful because I also like to have something that's a more governmental and official guideline they can follow.
Thanks, Prof. Eda. I think Jaimini,
No.
would
Hi.
you like to? Yes.
Yes. Thank you, Justice, for the great presentation. There was a lot of learning and a lot of insight. I don't know if I missed it, but I needed to take your opinion on the gases that are used in theaters and the waste that comes from inhalers and its effect on the environment. The initiatives that you've done, is it only on formulations as such, or where you've documented that initiative where something about the drugs is going to go all the way to CDC? Does it also include the waste that comes out from inhalers?
Before you answer, can I ask Justice? Can I just ask Elodie to ask a question? Elodie Yard. Okay. Yes, please go ahead. Oh, okay. They can't. Maybe type your question in the chat while Justice responds quickly.
Yeah, thank you. Yeah, you can type in the chat. because I know you may have questions on the neglected tropical diseases. So I think I'll leave the in-hospital theater emission issues to Professor Eda to mention, because she did bring up that in her presentation. I'm only soon going to interact with one of the private health facilities here in Kenya who wants support on development of a sustainability strategy, and they don't know how to go about it. And one of the things I've already thought about is the theater, because I know theater emissions is a lot, and it's not been documented. But my focus was mostly on the procurement systems we have regionally, nationally, and I was looking at the plastic packaging. I wanted the plastic packaging to have a normal end of life, not one intercepted by incineration before it even reaches the patient. So I was tracking that plastic so that it can now get down there. Then we can look at the waste collectors and what they do with it and see how the sorting is done, because those are the next phases. And beyond there, this plastic came from a petroleum base. It can go back to the petroleum base because it can be used to generate energy in a chamber that is controlled with proper reagents and air pollution control devices. We can contribute this energy back to the grid because it's working. There are people who are doing waste to energy. So for me, I was just tracking the HDP because it has a lot of emission. But over to Professor Eda.
Sorry, can you just repeat the question to get it correctly?
Who's Jaimini Gohil?
Hi, Eda. Thank you. My question was, are there initiatives to see how the emissions that come from inhalation gases and all in theater that have a big impact on the carbon footprint? Are there any initiatives to manage that? And the second part has been answered by Justice, but I needed your advice on that.
Yeah, no, certainly there. You can hear me, yeah. Definitely there are initiatives. There are a lot of initiatives happening currently at the NHS in the UK. So you can have a look at it. You can also have a look at Healthcare Without Harm Europe. There are also initiatives measuring that. They are also capturing machines possible. They are capturing narcotic gases that are also available and become more and more available. But then there are also guidelines, as I mentioned, available just to switch and phase out Destron and switch to other anesthetic gases and inhalers. And there are also tables available when you can, just switch from propellants to non-propellant inhalers. That's all available. Good source probably is to address and ask Healthcare Without Harm to provide the sources.
So thanks, Eda and Justice. Elodie did send a message on the chat. Yes, it has to do with NPVs. But I think his question boiled down to cost. Who is covering the issue that they had with this, as you explained, Justice, who is covering the cost? Just from your experience, if you can quickly touch on that. We are over time, and so yes.
Okay, thank you. So I'll be direct on this. In a number of situations, countries, ministries of health have covered the cost. It's amazing how they came through at the hour of need, especially if you're dealing with a reputational risk of civil society taking you to court for denying them medicine access. It's for social good. That's why I said leadership and governance in interconnected system. You need to balance between health equity, health access, climate action, social equity, so you have to balance all those needs. So ministries have come through. There are situations where I turn to the WHO for diplomatic immunity to avoid the revenue authority from taxing the commodities. And WHO came through and they gave a letter and they were the consignee receiving that donation from another country and it was distributed directly. So you have to play different glass balls, like political capital. Thank you.
So thank you so much. I think this is a great webinar, and I would like to once again thank Prof. Eda as well as Justice for availing yourself to present at our webinar. Yes, this is our last webinar for the year, but we're looking forward to a very exciting 2025. If you still want to join the network, you can scan the code and join the network to receive updates on various initiatives that are happening across the African continent. And we will be sharing our schedule with upcoming webinars. We're very excited to have this in 2025. So thank you so much, Justice, and thank you so much, Prof. Ida, for availing yourselves today. And to our colleagues online, we just want to thank you for your participation and for attending the webinar. So thank you so much, everyone, and have a good day further.
Bye-bye.
Bye.
Bye. Thank you.
Bye-bye.